Thanks for choosing to take a look at the short video that I've put together about bunion surgery or hallux valgus correction. My name is Stuart Metcalf. I'm a consultant podiatric surgeon. My NHS post based in the South Coast for Solent NHS Trust, but I'm also a consultant at number 9 Harley Street in London. I'll talk you through how the operation is done, some of the options that you have for your anaesthesia, and perhaps most importantly, a quick note on the recovery. One thing to say, if you're having bunion surgery or any foot operation, make sure you have it done, if not by myself, by somebody who's got plenty of experience. The foot is extremely complex and you should be having this operation done by somebody with a vast amount of experience. The last thing you want is to be somebody's guinea pig. So let's take a look at what a bunion is all about, why that is painful, and why you might want to consider having the foot corrected sooner rather than later. So in my short video we're going to look at a few things. Firstly, we'll look at what is a bunion, some of the causes of bunions or hallux valgus. Most importantly, we'll then look at the factors which will influence when you should choose to have bunion surgery and when it's okay to leave things alone for the time being at least. I've included here an animation of the most commonly performed and one of the most reliable modern techniques in correcting bunions, and that's the scarf osteotomy. And the final section will be a summary of what you can expect in your recovery. Anyway, I hope you enjoy the presentation I've put together for you. So most people think of a bunion as simply a situation in which the big toe twists inward and sometimes presses against the second toe. Commonly, patients notice that shoes begin to become difficult to accommodate. A bump develops over the side of the big toe joint, and this can sometimes become red and inflamed. They may find that they get pressure from the side of the toenail, particularly between the first and second toes, and it's not that uncommon for some patients to develop ingrown toenail type syndromes, together with hallux valgus or bunion deformity. The one thing that is pretty certain in nearly all patients is that bunions, once they start to form, progress with time, and the rate of progression usually increases with time. We'll look next though at an X-ray where I'll show you just how much more involved the bunion is than simply the bump on the side of the big toe joint. Bunions are a complex derangement of the whole of the forefoot, and they involve more than just the big toe joint, as we'll see next. So hallux valgus is much more than a simple bump on the outside of the big toe joint. Although this is a key part of the deformity, if you look at the X-ray here, you'll see that the cartilage of the joint has become abnormally positioned due to compression of the toe across the joint surface itself. A useful way to think about this is to consider your car tyre when the tracking is out and how the tyre will wear abnormally, as I've shown in this picture here. This is important because it can lead to the development of secondary osteoarthritis. Additionally, as the big toe pushes across, it can cause elevation and deformity of the second toe. This in turn can cause not only problems with corns and callus over the top of the second toe joints, but also overloading underneath the second metatarsal head. Many patients complain of difficulty with shoe fit because they find their shoes become ever tighter. This is not just because of the bump that forms, but rather because of the foot splaying out due to an increase in the distance between the first and the second metatarsals, as shown by the arrows. Also, underneath the metatarsal head are two small bones called sesamoids, and these become abnormally displaced as they erode away the undersurface of the metatarsal head. So as you can see, the bunion deformity itself is quite complex and involves structural change within the joint and the bones of the forefoot. We'll look next at an example of a severe bunion, just to see how clinically this might manifest. So here's an example of a patient who's left their bunion, not bothered to get it treated, and they develop quite significant deformity. You can see the very obvious bump over the medial side of the joint. The area has become inflamed. I've got some callus, and actually in this particular case has resulted in a small ulcer forming with previous episodes of infection. On the other arrow you can see that the metatarsal itself has lifted up and there's this kind of rocker bottom foot appearance. The bunion is so bad that the patient's weight is being borne under the second, third and fourth metatarsal heads, and the first metatarsal, which should be the strongest, is taking virtually no weight whatsoever. The big toe is pressing over the top of the second toe in this case, a less common feature, as normally the second toe overrides the big toe. Nonetheless though, this patient has left her deformity so long that she now requires a more complicated solution to fix it than had she sought treatment much earlier on. So we've looked at some examples clinically and also on X-ray of how bunions can influence the whole of the forefoot, giving rise to not only pain around the big toe joint, but also secondary foot deformity and foot pain. The cause of bunions is not absolutely clear. There is certainly a genetic predisposition, as bunions often run in families. The condition can sometimes skip a generation or so, but usually if we ask the patient if they have a first degree, second degree relative with bunions, there's normally a positive family history. This is useful in understanding what the bunion may look like in the fullness of time and can serve as a useful guide to the patient as to what their foot may develop into if left untreated. Footwear is a commonly cited factor, though we don't believe is a primary cause of hallux valgus in itself. We do know that poorly fitting shoes such as stilettos and very tight narrow pointed court shoes are likely to exacerbate the development of hallux valgus. There are several other biomechanical factors which we know are important. Things such as instability of the first metatarsal, ligamentous laxity in conditions such as Ehlers-Danlos syndrome, Marfan syndrome and the like. These can all be important. Finally, it's worth just mentioning that there are some types of arthritis such as rheumatoid and indeed gout, and also sometimes osteoarthritis can predispose the joint to developing a hallux valgus deformity. What's really important to understand is that the natural progression of a bunion is to get worse over time. There's no conservative treatment that's proven effective, and really surgery is the only reliable option for patients that have hallux valgus deformity. Left untreated, the deformity will progress to a point in which the patient will require a more complex procedure than in the early stages. The other thing to bear in mind, of course, is that as the deformity develops and over time, the big toe joint will often develop secondary arthritis, and therefore the long-term results of bunion surgery are less good in those that have sought treatment late compared with those that have acted promptly to get the condition treated properly. Nowadays, bunion surgery is safe and effective and extremely reliable when you're in the hands of an experienced consultant. I've performed well over 20,000 foot operations in my career to date. What's important is that you pick a consultant who has particular expertise and skill in performing this type of surgery. You should consider bunion surgery really when you have deformity of the big toe joint, but before any significant arthritis has occurred, and certainly don't leave it to the point in which the foot has splayed so much that you require a much more complicated procedure. On the right hand side you can see the picture of a typical post-operative patient at only 3 days after their operation. This is the very first redressing appointment. The X-ray picture on the left shows the scarf and Aiken osteotomy, which is performed by myself for the vast majority of patients with hallux valgus deformity. This operation is technically quite difficult and certainly takes many years of experience to learn and develop. Having done many thousands of scarf and Aiken osteotomies, I know that the operation can be adapted to suit the individual needs of you as a patient, taking account of the type of deformity that you have, degree of displacement of the sesamoid bones, bone quality, and the presence of any joint damage. The X-ray shows a pre- and post-op picture, and in this instance, the metatarsal bone has been fixed together with 2 titanium screws and a special threaded K-wire in the base bone of the first toe. So the difference would be that if this patient had left the bunion untreated, instead of being back on her feet within 2 to 3 weeks and back at work, certainly in this instance within 4 weeks, they would have required an operation involving a below-knee plaster cast, and probably this would have had to be in place for up to 12 weeks. Let's have a look then at an animation that I've put together that allows you to see on a model how this operation is performed. So step 1 is where we meet for the first time at a new patient consultation. During this appointment, we can discuss aspects of your medical history and make sure that medically you are fit and well for this day case type procedure. I'll take a deal of time to explain to you, having assessed your foot thoroughly by checking the circulation, sensation, and also how the joints of your feet move. I'll also be able to explain to you what your surgical and indeed your non-surgical options are with respect to your particular foot problem. Most likely, we'll then move on to making plans for the next step. This will involve me sending you for an x-ray of your feet during standing up position, so I can then evaluate the alignment of the bones of your feet and also the joint cartilage status. Of course, you can come and see me at my clinic in 9 Harley Street in London, my other clinic in Chingford, or indeed my private clinic in Spire Parkway Hospital in Solihull. It doesn't matter where you see me, you will still receive a detailed assessment and in particular a thorough explanation about the options before we make a plan to review you next with your x-rays. And this will be step 2 in the process. At the end of the first consultation for Bunions, I'll normally send you off to have some x-rays done of both feet. We'll meet usually the following week to discuss the results of your x-rays, and I can talk you through very carefully exactly what the alignments tell me, what the state of the joints are in terms of any arthritic change or cysts within the bone, so that you can fully understand the impact of the bunion and what it's done to your foot before we plan any further treatment. We'll also talk again about the goals that you want to achieve from any forthcoming or future foot surgery. And if surgery is the right thing to do and the right way forward, having had this discussion, then we can agree a date, decide between us what the best choice of anaesthetic is for you as a person. You have the options of being fully awake, being asleep, or having sedation, and we can cover these things during this second consultation. The most important thing as a patient is to understand that the consultation time with me is your opportunity to have answered questions that you have, and I will hope that I can prompt some of these during our initial and subsequent meetings. What I like to do is to agree a very clear treatment plan at this initial review appointment so that you know what to expect in advance of coming in for your day case foot surgery. Let's look then at, albeit in brief, the kind of process that takes place when you come in to have your foot operation, and then we'll finish off with a summary of the typical recovery times, and these are generally a guide and of course will be influenced by things such as your occupation and the type of operation you've had done, but they're a very good guide.